Good afternoon, ladies and gentlemen. Welcome to day 2 of the 12th Singapore AIDS Conference. My name is Jing. I'm a senior clinical staff at Action for AIDS, the anonymous testing and counseling program. It is a great honor to be your MC today. For those of you who are attending for the first time, Singapore AIDS Conference is a biannual event that was first held in 1988. This year's conference was co-organized by Action for AIDS, the Department of STI Control, the HIV program of the National Center for Infectious Diseases and National University Hospital. Thank you all for joining online. Throughout today's program, we have clinicians and researchers, community leaders and policymakers, as well as persons affected by the HIV epidemic to share their insights and knowledge with us. Please don't hesitate if you have questions for any of our speakers. You can type your question in the Q&A box, which is located at the bottom of your screen. At the end of each session, we will address as many of your questions as possible. Please also know that by default, you're joining the conference in audio-only mode. If you get disconnected, just click on the Zoom link again, and we will let you in. Now, I would like to invite Professor Roy Chan to welcome our first plenary speaker. Over to you, Prof.
Can you hear me loud and clear?
Yes.
Okay, great. Good afternoon, and thank you for coming to our day 2 of the 12th Singapore AIDS conference. We have a really good lineup of speakers and panelists, and I'm certainly looking forward to all the discussions today. It is my pleasure and honor to introduce our first plenary speaker from webinar 3. He's Professor Andrew Rulick, who is the Theme Director, Populations and Prevention, and Head of the HIV Epidemiology and Prevention Program in the Kirby Institute of UNSW, University of New South Wales. To provide a bit of background, the National Center in HIV Epidemiology and Clinical Research was established in 1986 in response to the AIDS epidemic. And on its 25th anniversary in 2011, it changed its name to the Kirby Institute. He's a member of the Governing Council of the International AIDS Society, where I believe his and my terms overlap for a couple of years. He's also a fellow of the Australian Academy of Health and Medical Science. Professor Grulich is one of the most important global leaders in research on the prevention of HIV and sexually transmitted infections in gay men. For example, he was principal investigator of the Opposites Attract study, one of the cornerstones of the Undetectable Equals Untransmissible campaign, and principal investigator of the EPIC New South Wales study on population-based PrEP rollout. Some of you here will remember that he was a keynote speaker at the 6th Singapore AIDS Conference in 2008 when he spoke of the Australian experience and what makes an effective HIV prevention program. Australia has been a world leader in AIDS prevention, treatment, and advocacy. And we have been very fortunate to have had a long and close relationship with many Australian HIV and STI experts. We have benefited from interacting with their experts at meetings and conferences, as well as study tours to their centers of excellence and their community organizations. It has been my hope for a long time that our own program be as holistic and comprehensive as Australians. In fact, all of the 4 plenary speakers at the 12th conference are Australians. I was joking to Sharon Lewin that we might as well have called it the Singapore Australian AIDS Conference. Professor Grulich will be speaking today on PrEP, implementation and scale-up, the experience from Australia. Over to you, Andrew.
Thank you, Roy and Jing, and thank you very much for the opportunity to present to you today. It's a real honour, and it is quite amazing to think that the last time I spoke to this conference in 2008, we didn't have PrEP and we didn't have treatment as prevention. So things have certainly changed. So today I will be talking about the PrEP implementation and scale-up in Australia. And I start with this photo, which is actually from Australian campaigns, but in multiple languages. And if you take one thing from my talk today, I'd like you to take that wherever you are and whatever language you speak, PrEP is a very highly effective form of HIV prevention that should be a critical element of any comprehensive response that aims to end HIV. Having said that, it is a bit important to the story I tell that you know a little bit about Australia's response to HIV. So very quickly, here are some of the key elements which I think underlie our success. One of the major ones is that HIV is not a political issue in Australia. It's very much a bipartisan issue between our two main parties. And we know that we can rely on a science-based response, similar to the COVID response, in fact, which has been very science-based in Australia. The response recognises a formal partnership between leadership from the government, of course, but also from community organisations, clinicians and researchers. And every 3 to 5 years, we have a new national HIV strategy, which is written by the Federal Health Department, our National Health Department, but with a lot of input from the Ministers' Advisory Committee, which is an expert committee containing members across that partnership. And each of these strategies, particularly for the last 10 or 20 years, has had quantitative goals and targets. So there is a way of measuring its success or indeed its failure. And lastly, one other thing that's important in the PrEP field is that we have a national system of funding pharmaceuticals, which is based on cost effectiveness. So new agents do need to be proven to be cost effective before they get introduced. And then once they are introduced, there's a fixed price co-payment at the point of sale of about $40 per month. I think the Singapore and Australian dollars are very similar at the moment, so I don't need to translate that amount. But that amount is, less than $1 a day, so it's affordable to the great majority of people, and people without jobs get it for $6 a month. One slide on the back on HIV in Australia before PrEP. So it is predominantly gay and bisexual men in Australia, about 70%. And in 2016 was when we really started to introduce PrEP broadly. We had actually, at least in my state of New South Wales, reached the UNAIDS 90-90-90 goals of 90% tested, 90% on treatment and 90% with undetectable viral load. But our infections were rather stubborn. So you see here for the decade up to 2016, we had about 1,000 new infections a year in Australia, with 70 to 80% of them in MSM. So it seemed like treatment as prevention on its own in Australia was not enough. So here's the timeline that I want to take you through today from the first in principle support to the current day. So when did it begin? The first mention of PrEP in our strategies is about 2012, relating to the fact that our first evidence of PrEP efficacy in men who have sex with men were published in 2010. So my state, New South Wales, tends to be the leader in this field because it has the largest epidemic. And in this government strategy, the first tentative steps were taken towards PrEP availability, noting that the clinical trial results were very recent. And at that stage, we were very tentative. We were saying that it had potential to be a prevention option for a small number of people at very high risk of HIV, and that the government would consider the application to non-trial settings and how to most appropriately and efficiently implement it. So I'd call that lukewarm support. It wasn't by any means strong support. But the overarching goal of this strategy was that we would work towards elimination of HIV. In 2014, we saw the release of the first guidelines, which were based on US CDC guidelines, which were released that year. So we were quite soon after that, New South Wales guidelines were released. And these were linked to small-scale demonstration projects in 3 states of Australia. And this is typically the way this has happened around the world, that when places start this up, they do a small-scale demonstration project to convince people that it's going to work. And these three studies in total around Australia were less than 500 men. The initial guidelines we had were based on the highest risk gay and bisexual men, looking for most bang for buck, if you like, than people at very high risk. And then these projects showed that the demand was very high. This was, I think, initially somewhat surprising because our community organisations at that time had not been promoting it, but gay men are quite health literate in Australia, and they'd heard about this new treatment and they wanted it. We had no trouble getting these targets very quickly. We showed adherence was excellent. Now, this is absolutely critical because if you don't take your drug as prescribed, you don't get prevention. And in about 500 person years, we saw no infections. So this is what was needed, really, these studies between 2014 and 2016, to convince members of the partnership that PrEP is something that could work for individuals in Australia. The next step was to think about rolling out, and this is where governments were really quite reluctant. That they were worried that this was an expensive drug at the time. In 2015, this was an on-patent drug in Australia with a cost of about $10,000 per year, and that for a preventive drug, that seems like an enormous amount to pay. So we conducted some eligibility estimates that were based on population-based data on the proportion of the population identifying as gay, and we used a figure of about 2%. We used behavioural surveillance to look for men at high risk and cohort study data on HIV incidence. So this table here shows you the risk factors we came up to based on cohort data in Australia, looking at populations which had an incidence of at least 2% per year. So the risk factors initially that were required for a person to be prescribed PrEP was that they had a rectal STI or infectious syphilis. They reported condomless sex with a positive partner who had detectable viral load, or they reported receptive condomless sex with casual partners whose status wasn't known, or they were crystal methamphetamine users. So we were helped here by local studies where we could see that these were the highest risk factors. And this focus was very much on the highest risk to start with, again, because we didn't want to worry the people paying for the drugs that this would be used by a very large population. And this resulted in an estimate in New South Wales that about 9% of sexually active gay men would be eligible for PrEP, and that came up to 3,700 men in our state, which is about 7 or 8 million people. The next big step, and this really did make things move much more quickly, was firstly by conference presentations in 2015 and then publications in 2016 from the PROUD study in the UK and the Epidemiology study in France, that oral PrEP is virtually 100% effective in people who were adherent. The previous data from the IPREC study in South America was somewhat less conclusive about the degree of efficacy. But it was clear from those studies that if you take it every day, it's about 100% effective. It was also clear by then, based on studies in men and women, that PrEP works best to protect against transmission through rectal sex. And in that settings, there is a really quite lenient requirement for adherence that, in fact, as long as you're taking 4 pills per week, the levels are sufficient to provide protection. That's absolutely not the case for vaginal protection, where daily adherence is required. And by 2016, it was fairly apparent that PrEP failed almost entirely when people didn't take it. So it was adherence that was the important thing. There have been a few case reports of failure in adherent gay and bisexual men, but really there's about half a dozen of those have been described globally in something more than hundreds of thousands of gay men who have been on PrEP. So at the same time, our governments wanted us to answer the question. Okay, they basically said to us, okay, we get you, we understand that this works at the individual level, but what about at the population level? Can this help us end the epidemic? And really, the answer to this should be fairly obvious, based on the fact that at the individual level, this is close to 100% effective. The answer to the question has to be, if you get people at risk taking that treatment, you can have a dramatic impact. So our modelling, when we looked at targeting to the highest risk gay men with high coverage, so trying to get almost all those high risk gay men on PrEP, and doing it quickly showed that theoretically you could get an extraordinarily rapid reduction in HIV. It did depend, of course, on being able to do these things, which is not easy, but nevertheless, it was energizing to the gay community in particular that this was something that was theoretically possible. Of course, you can have much lower levels of rollout, and that's fine for the individuals who are taking PrEP. It will still absolutely protect them, but you get much less reductions in population level incidence. And with good levels of coverage, you then get herd protection with, you get some herd protection with disrupted chains of transmission. So on the back of those sort of results, our next strategy, our next New South Wales Health Department strategy had the same overarching goal of virtual elimination of HIV, but it was very bullish about PrEP, calling it the next critical addition to HIV prevention, that it need to be expanded across the state, and we needed to expand access to PrEP to all people who are at high risk of infection. So that led then, in early 2016, to the launch of large implementation studies. This was on the back of political commitment, essentially. And because at that stage, oral co-formulated tenofovir and emtricitabine was not licensed for PrEP, in Australia, this needed to be done in a clinical trial framework through our regulatory agency. We notified that we were doing a clinical trial. Now, the rather fortunate consequence of that is that because it was a clinical trial, we were legally able to import generics at much, much lower cost than the advertised full cost of the drug of $10,000 a year. In fact, we were able to source the cheapest generics that we could find for the conduct of the study. And that this study tried to look at the population level effect. The demand was extremely high. We met the target within 8 months and then continued without cap. And it was supported by a lot of campaigns from the gay community. In the end, we enrolled about 16,000 gay men across almost every state and territory of Australia. At the same time as these studies were ongoing, the government started to talk about federal subsidy for this treatment, and so cost effectiveness analyses were the next logical step. We modelled various situations of coverage where you would have high-risk gay men, medium-risk gay men, and low-risk gay men. And of course, the aim is to get most high-risk gay men on PrEP and not many low-risk gay men on PrEP, because it's a waste of money in low-risk people. And in these sort of situations where you get very high penetration of the high risk, at usual acceptable thresholds of willingness to pay, the price of PrEP would need to be $2,000 to $3,000 per year, as opposed to the $10,000 per year that it was being marketed at the time. However, we were very fortunate that in the process of doing this, the patent for the drug did expire in early 2018, and we were able to offer generic PrEP to everybody in Australia who needed it. And so then in the national HIV strategy now, we have very much encouragement for PrEP use, and we have now a quantitative target that the proportion of eligible people, and that's largely in the Australian setting, high risk gay and bisexual men, that 75% of them should be taking PrEP. So in 2018 then we transitioned from those studies to publicly funded PrEP, and so as soon as the drug became available as generic, we transitioned people to publicly subsidised PrEP. We had a lot of social marketing, and more recently we've started to relax these guidelines to allow a lot more clinician discretion about who would benefit from PrEP. We now monitor PrEP through that's provided through our pharmaceutical benefits service, and these are data on the quarterly starts of PrEP in this yellowish colour. You can see that we've now had getting up towards 40,000 individuals who have been prescribed PrEP, and then in this blue colour the number of recent prescriptions, and you'll see we have had a small decline due to COVID-19 in 2020, with some men stopping taking PrEP. We are now monitoring whether we're getting enough coverage through this mechanism of behavioural surveillance called the Gay Community Periodic Surveys, which tracks the percentage of all gay men and of high-risk gay men who are taking PrEP. And you can see this rapid increase in the proportion in dark red of on taking PrEP, which is now 70% of high-risk gay men nationally are taking PrEP. It's still not quite at the target, and in fact the new New South Wales strategy, which is going to be released in the next week, will target 90% rather than 70%. And about 1/3 of all gay men are now taking PrEP. The impact within the EPIC study in New South Wales was considerable. We've seen an incidence overall of 1 to 2 per 1,000 person years, which is about 90% less than would be anticipated without PrEP. We do see infections. We've seen about 30 in this very large study of almost 20,000 person years, but they're all in men who were not taking PrEP at the time of their exposure. And by the end of the study, by the end of about 3 years, about 2/3, the medication possession ratio had declined to about 2/3. But that's mostly in men who have decreased risk. And in fact, in those men who are taking all their pills, we see no infections. At the population level, in New South Wales between 2015 and 2020, we've seen a 24% decline in HIV overall. We've seen an over 40% decline in Australian-born MSM, and we are beginning to see disparities. So lower declines in overseas-born men who have sex with men, those men living outside of the inner city, and younger men. But in the inner city of Sydney, where the epidemic used to be concentrated, we've now seen a 75% decline, an extraordinary level of decline. Just quickly, I know my time's nearly up. We have seen changes in behaviour. It is now the case that PrEP is the main HIV prevention strategy used by gay men. It has overtaken condom use. And on this figure, tracking gay men over time, 2015 to 20, in our behavioural surveys, red is those who report condomless anal sex, and you see that is declining. Condomless anal sex is on the decline, but PrEP use, condomless anal sex without PrEP use is on the decline. PrEP use very much on the increase. And so this net prevention coverage, all of these behaviours here is on the increase, which is why we're seeing the declines in infection. One slide on sexually transmitted infections. I know people are very concerned about this, and this is a high risk population, and therefore you do see a lot of sexually transmitted infections. But I will say that the decrease in condom use is counterbalanced by increased screening and increased treatment. And if you have more treatment and increased diagnosis, you get reduced prevalence. And in EPIC, we saw essentially flat rates of STIs. They are very high rates of STIs, but they did not increase. So to round up now why we have been so successful, these are all things that I've talked about: political support, having targets, having a primary care system that works well is also critical. Having PrEP be cheap is critical. PrEP cannot be, when we're talking about a preventive drug, we can't be spending $10,000 a year or more on that. But I would point that, many of you will look at that and you might say, oh, I wish we had that. I would say that PrEP should be able to work anywhere. I think at the end of the day, we need to remember it is almost 100% effective. PrEP delivery is actually clinically simple. It is not a complex intervention. And once educated, our people at risk absolutely want PrEP. Whenever I give a presentation on PrEP, I do highlight that PrEP shouldn't be promoted to the community on its own. Gay men now have a choice of HIV prevention techniques: condoms, PrEP, or if you're HIV positive, keeping your viral load undetectable. They're all highly effective forms of prevention. And just to finish with, I work with an enormous number of people here at the Kirby Institute, but also across the health department, the community-based organisations and clinicians. Thank you very much. I look forward to our discussion.
Thank you, and that was a really wonderful, comprehensive, detailed description of how of the last 6 to 8 years actually on PrEP rollout and research. And just one question to start off, I guess, is is the costing, and the $40 a month. Is it $40 a month?
Yep.
And that's the cost to the health service, or the cost to the patient?
That's the cost to the patient. The government, when we first funded PrEP, the drug cost the government about $2,000 a year. My understanding is that now, with more generic companies in the market, it's down to about $1,000 a year. But the patients pay $40 a month. If they're Medicare eligible.
Right. Is there anything in addition, like consultation and labs? Or is that?
Yeah. So in the Australian system, the primary healthcare system, firstly, people have access to sexual health centres which consultation is entirely free and the labs are entirely free. Many people will see private general practitioners where there may be a small copay, but free options are alternative in sexual health clinics.
Thank you. One other question is, what about, you say there are about 70% of the HIV load is MSM in Australia.
Yep.
The other 30%, I imagine, would be heterosexuals and a bit of people who use drugs. And sex workers, are they rolled out? Is PrEP rolled out for those groups as well?
It's not, Roy, because except in very particular circumstances, because we have almost no HIV in sex workers in Australia. Condom use is still very high, and the sex workers want it to stay that way, which is great. The only situation where it's routinely offered to heterosexuals is if they have a high-risk partner, because you can't identify a high-risk heterosexual in Australia. So it might be a woman with a bisexual male partner. That would be a situation where that person is eligible. Thus far, though, about 97% of PrEP prescriptions in Australia have been to men.
Thank you. I'm going to field some questions here from the audience. Professor Liu Yi-Sin, who is the director of the NCID here. That question is, how do you dissect the reduction in HIV incidence due to PrEP and due to control of viral load through treatment?
So it's obviously a very difficult task to do that precisely. What I would say, however, in Australia was that that by 2016 we had reached 90-90-90 and we were not seeing declines in HIV diagnosis. And I'm not suggesting that treatment as prevention does not have an effect. It's a critical part of the HIV prevention equation. But our data suggests that at least in an MSM population, that treatment as prevention on its own is not going to be enough to get declining HIV infections. And really, if you've got 10% of your people living with HIV who are not yet diagnosed and people are not protecting themselves, then you're going to get a lot of transmission.
Okay, another question here is, do you have any data in Australia how many men are taking PrEP on demand? In Singapore, it's used quite commonly.
Okay, so our guidelines did not support PrEP on demand until last year. And so we don't have great data on this yet, but it probably in the order of 5 to 10% of men are taking it at least part of the time, but it hasn't been promoted. We have got some campaigns that are about to be launched promoting PrEP on demand, so I suspect that will increase quite a bit in the near future.
Thank you. A question here regarding patents, which is always an issue everywhere and in Singapore as well as. So the question reads: before the expiry of the patents covering branded drugs, was there any attempt to negotiate new pricing models, given the volumes involved?
Look, I think that it's a really great question because in Australia now we've got more people on PrEP than we've got on HIV treatment. So you would think drug companies would come to the table and say, wow, we've doubled our volume, we're going to accept a price cut. In our experience, drug companies don't do that. So that didn't happen in Australia. But what did happen, as I mentioned, is that we did all of our rollout in a clinical trial setting. You may have seen the publications, and because we did it in a clinical trial setting, we were able to legally import generic drug, and that generic was the cheapest WHO compliant generic in the world. So we got a very cheap rollout in terms of drug price, and that was completely legal.
So I'm glad you brought that up because obviously in Singapore we have been, and you'll hear from the presentation later on, most of our citizens and people who live here are taking generics. There has been, might be less now, some reticence in terms of using generics, and maybe a couple of comments on that.
Yeah, we largely had transitioned to generics in 2018, and in fact, Gilead no longer market Truvada in Australia anymore. So there's only generics. We did get some people complaining that they felt the new pills made them feel different, but at the end of the day, in 2019 it was withdrawn from sale. So the drugs are formulated precisely the same manner. Yes, they're different colours, but I think as doctors, we're used to talking to patients about our blood pressure pills that are different between generic and originator compounds. It's no different from that.
All right, thank you. I think I've answered all the questions on the Q&A. Maybe just a comment on where do you think the role of Descovy is, the new the TAF formulation?
Yeah, so it is fairly clear from the trials that Descovy has slightly lower kidney toxicity, and there might be a very small proportion of the population who have abnormal kidney function who can't use Truvada. I would say we have a publication, we presented data on this, that we did monitor creatinine over time in this population, and it is extraordinarily safe, this drug. It very, very rarely causes kidney problems, and if it does, you withdraw it and the kidney problems get better. Having said all of that, there will be a small proportion of people with severe kidney problems who cannot take Truvada, and Descovy has a role in them, and the problem then is paying for it.
Great, thank you. I think we'll close the Q&A, and thank you very much, Andrew, for making your time, and it was really illuminating and I'm sure very informative to everybody who heard this. So I understand you're going to be staying on for the panel discussion, so he's here to answer any further questions. I'd like to hand over now to Rayner, who is the facilitator of the panel discussion coming up. Rayner.
All right, hi everyone. So thanks, Prof. Chan, for handing the time over. I want to just not take too much time introducing this panel discussion and this section of the conference. So basically, we'll be, there were some questions on, how has Singapore fared in terms of PrEP, and I think some of the presentations today will give you some insight into how Singapore has fared. I'm also excited to have Rina join us from Bangkok as well to be one of the panelists here. She'll be sharing a little bit more on community participation and how it's been like in Bangkok. So firstly, I just want to hand over the time to Dr. Benson Yeo, and let me introduce him very quickly for the first presentation. So Dr. Benson Yeo is a consultant at the National Skin Center and Deputy Head of the Department of STI Control, or DSC Clinic. He is also a member of the Executive Committee of Action for AIDS Singapore. He graduated from the Yong Loo Lin School of Medicine in 2008 and completed his specialty training in dermatology in 2016 with subspecialty interest in sexually transmitted infections. Dr. Benson Yeo will be talking about PrEP use at the DSC Clinic. Dr. Yeo, please.
Hello. Hi, thanks Rayner for the introduction. So I'm Benson, I'm from the Department of STI Control Clinic in Kelantan Lane. So I'll be talking on the PrEP use in the DSC Clinic and some local context of PrEP in Singapore. So some background. So PrEP is a pre-exposure prophylaxis by taking this pill, 2-in-1 pill daily, when event-driven, and is one of the methods in preventing HIV infection. It was first recommended by WHO in 2015 for HIV prevention in at-risk people. And it was first formalized locally in our center with a clear standard protocol since 2017. And I remember I first spoke about PrEP in 2018 at the 11th Singapore AIDS conference, the time PrEP in Singapore. So my talk will really be focusing on what has changed since then. I think these are the main points that have changed in our PrEP use. So firstly, we have facilitated medication access. We have streamlined investigations so that decrease costs and increase convenience for clients. There's a lot of increased PrEP awareness among people. And subsequently, there's a lot of increased number of prescriptions at DSC. And just to mention, actually, there's no been a rebound in number of STIs despite the large increase in number of PrEP prescription at our clinic. So how do we facilitate medication access? So DSC, like any other clinic in Singapore, has to carry the patented proprietary medication through VADA. And patients who want the convenience, complete assurance, and do not mind the premium attached do sometimes pay for it, a small percentage of them. Otherwise, examples of online middlemen to help patients source for their own medications overseas are given to them. And the cost may be as low as more than 75% cheaper than what the proprietary medicine costs. And over time, in the past year, through our engagement with these websites, they've become aware of medical concerns of use of PrEP, and they have been quite vigilant in asking for a prescription, and not only that, a dated prescription before they allow PrEP to be dispensed to them. So at DSC, about 88% of patients choose to source for their own medications from those websites mentioned, and about 12% choose to buy directly from us. And then investigations have been streamlined since we first started it. So in 2018, I mentioned about the prescribers paradox, where the people most comfortable using HIV medications are not the people prescribing PrEP, whereas those that don't use HIV medication now have to start using PrEP. So over time, we have started to become more confident in the safety and efficacy of PrEP. And the frequency of investigations have reduced. For example, now kidney function can be checked as infrequently as 6 to 12 months, depending on the patient's age and baseline kidney function. STI screening can be done 3 to 6 monthly or as determined by patients' reported sexual behavior. So this has all reduced costs and inconvenience for PrEP users. Demand has also increased because of increased PrEP awareness through both mainstream media and social media. So Straits Times headlines over the past year, there are quite a number of them just on PrEP itself. And social media like Grindr, where I think the period of time there was this just pop up, where everybody that logs into Grindr will be notified about PrEP. So awareness increased and subsequently demand has increased. So these figures was courtesy of from Jing from AFA. The majority of clients surveyed at AFA actually has heard of PrEP, 80%, and almost half of them surveyed over 3 months are currently using, previously used, or considering future use of PrEP. Specifically, only 21% of people surveyed have never heard of PrEP before. 35% have heard of PrEP but are not considering it, while the rest, like 16% are using or previously used PrEP, and 28% are considering PrEP use in the future. So with these three factors, facilitating medication access, increased PrEP awareness and demand, and streamlining investigations and prescribers' confidence, there has been a large increase in PrEP prescriptions since 2019 at the DSC Clinic. So you can see in 2018, there was only 70 prescriptions, then jumped up to 418 in 2019 alone. This year, because of the circuit breaker and COVID-19, it has dropped to 294, but this figure is just up to September. I expect it to increase and maybe even catch up to last year's figures by the end of the year. Concerns about rebound in STIs because of risk compensation behavior is quite common, but despite the rapidly increasing prescription of PrEP, there has been no sharp increase in notifiable sexually transmitted infections. And correspondingly, the number of new HIV cases among Singapore residents has decreased in recent years. So for 10 years, from 2007 to 2017, the number has not budged from 400 to 500 per year. But from 2018 onwards, the number had actually decreased to 310 to 330. I mean, I cannot just say it's because of PrEP, but I mean, it's coincidence. So there's no rebound in number of STIs seen despite the increased use of PrEP from 2018 to 2019. So for gonorrhea and syphilis, the percentage has decreased by 6%, 21%, respectively. Chlamydia had a small increase at 7%. So moving forward, there's a possibility of availability of generic PrEP soon in Singapore after the expiry of patent of Truvada. And then we also have the second drug that we know has been approved for use as PrEP by the FDA in October 2019, that's Discrete. It is, of course, by the same company as the makers of Truvada, just as the patent is running out. And this Discrete patent, of course, will last for several more years. There's a few limitations compared to Truvada. It's only approved for men and transgender women because less studies compared to the original TDF and prisotropin combination. Lower risk of renal toxicity and decreased bone mineral density, but like Prof. Grulich mentioned, is there really a clinical significance? And the cost is, of course, much more expensive expected compared to the generic medications. So in summary, use of PrEP has picked up significantly over the past 2 years locally, from 70 prescriptions to more than 400 prescriptions of PrEP a year at the DSC Clinic alone. Multiple factors have contributed to this. So easier access for patients to import generic medications at a fraction of the cost for personal use. Increasing prescribers' confidence and ease of use, streamlining number and frequency of investigations, and increased awareness via mainstream and social media and dating sites. STI rates have not spiked despite increased risk of PrEP, putting at ease worry regarding risk compensation. On the other hand, HIV rates has correspondingly decreased in tandem with increasing PrEP use. Moving forward, so moving forward, patent for Truvada is expiring soon, which can allow for even more easier access to generic medicine locally, hopefully by next year. And a new drug approved for PrEP may be suitable for certain demographics of patients. Thank you.
All right, thank you, Dr. Benson. So I see some questions coming in. We'll address them towards the end through the panel discussion. So now I'll move on to the next presentation, which is by me. So I'll keep my introduction very short. I'm just finishing up my PhD at the Sociology School of Public Health at National University of Singapore and the National University Health System. And okay, let me just see how I can get control of the slides. Okay, great. So right now I'll be speaking a little bit about, we know that PrEP is efficacious. We know that, PrEP has a role to play in the HIV response. But I think one thing that we hear less of is what can we expect from scaling up PrEP? How do we model the impact of PrEP on HIV? And perhaps also one thing that I'll talk about today is risk compensation amongst MSM or men who have sex with men here in Singapore. So HIV PrEP, we believe that we can actually get to 0 new infections among MSM in Singapore by 2030. So I'll tell you why. Why focus on MSM? So my research has been based in MSM, and basically the incident yearly HIV infections that we have here in Singapore, a majority of them are among MSM. So to deal with HIV in Singapore, we have to deal with HIV prevention in at-risk groups as well. I won't belabor this point. We all know that the efficacy of PrEP has been established, underpinned by many clinical trials. Even though I put the figure here as more than 90%, actually this is, it ranges because of adherence issues. As Prof. Rulick already mentioned earlier, with high adherence, it's high efficacy as well. Also, I think Prof. Grulich covered, the effect of PrEP or effectiveness of PrEP at a population level, through large-scale implementation, population cohort studies. In San Francisco City as well, since the approval of Truvada for PrEP, we've seen a decline in the yearly incident HIV infections. So there have been some evidence, to underpin PrEP's efficacy as well as effectiveness at the population level. So PrEP was rolled out in Singapore in late 2016. How have we been doing in terms of the MSM community? We did some studies from 2017 onwards. So in 2017, this was a study conducted on Grindr among 1,025 MSM. So we found that actually these figures kind of reflect the figures that were shown earlier, by Dr. Benson, that was collected at Action for AIDS. So 15% of the sample had ever taken PrEP. 18.8% had never heard of PrEP. This was in 2017. And actually a majority of MSM, about 60 to 65%, would take PrEP or would consider taking PrEP. Those who did not consider taking PrEP felt that they weren't at risk of HIV. They had some concerns over cost, access, and anonymity as well. So this one was also based on qualitative studies, focus group discussions with MSM and transgender women back in 2016 and 2017. These were not conducted or rather PI'd by myself, but they were run by the team at NCID, or back then it was IIDE, Institute of Infectious Disease Epidemiology. These focus groups also raised the issues of anonymity and cost for PrEP. How have we been doing in the past few years though? So actually, if we look at the incident HIV cases from 2012 to 2019, we have seen a slow decline in the cases in the past few years. But actually in the past few years, if you split the data between heterosexual men and MSM, you'll see a steeper decline amongst MSM in 2018 and 2019. So actually what we are seeing here could potentially be the impact of PrEP, as we know that, in 2017, we've already seen MSM starting to take PrEP. More importantly, if you look on the figure on the right, actually this is work done by my colleague Cheng Yue at the Swee School of Public Health. Her supervisor is Professor Alex Cook. We see that when we model the impact of PrEP over the next few decades, at the baseline where we are at 15%, it is the yellow band over there. If we stick to 15% at where we are at as an assumption, we can actually see incident HIV infections drop amongst MSM year on year. And, we actually see it exceeding beyond the graph itself, which means that actually, okay, we're going to see a decline in incident HIV infections, but the decline is going to be slow. If we were to increase coverage of PrEP to up to 50%, actually what will happen is that we'll really eliminate onward transmission of HIV amongst MSM by the year 2030. So that is the potential of PrEP here in Singapore. One thing that has been on the minds of, I guess, policymakers and researchers in different settings is this idea of risk compensation. That has been a huge barrier towards the pickup of PrEP, implementation of PrEP, and factor in reluctance to roll out PrEP. So what does risk compensation actually typically entail? So because PrEP reduces the risk of HIV infection, what happens is that when you think that your risk is lower, you might engage in more behaviors that are associated with HIV risk. And what that leads to is more sexually transmitted infections. When we think about the evidence that's already available out there, what we're actually seeing is that, okay, amongst people who use PrEP, there might be a higher burden on STI, there may be higher measures of increased conjugal sex, but actually these factors or these measures tend to take place only amongst MSM who have already exhibited such behaviors or who are already at risk prior to taking PrEP. So that's the evidence that we have from systematic reviews that have been published in scientific journals. So with this in mind, we were thinking, what about Singapore? How can we expect PrEP to affect risk compensation here in Singapore amongst MSM? That is a question that we are asking as we did our last study on PrEP implementation amongst MSM. So this study was also conducted through a collaboration with Grindr. We actually wrote out what we call a discrete choice experiment. It is a 10-minute survey, and this survey, I will show you some details in the next few slides. So we recruited 648 MSM, and what this survey meant to do was to measure utility scores of preferences for different types of PrEP attributes, as well as risk compensation. This is how the survey looked like. So when participants started doing the survey, they were given some information on PrEP just to standardize the knowledge on PrEP. After that, they were asked if they thought they were good candidates for PrEP. And then they were led to the discrete choice experiment. This discrete choice experiment actually involved presenting to participants two baskets of prep choices. So each basket had different prep attributes. These attributes were actually determined through our formative studies. We know that cost is an issue, access is an issue. So we actually put all these different attributes into these two choice tasks. After that, they were asked to choose only between these two tasks that were presented. And through those choices, we were able to generate preference scores or utility scores. After that, they were asked to compare if this choice that you chose was a PrEP-only option. You cannot add anything else to it. You cannot add condoms. Between this PrEP-only option, would you choose condoms only or PrEP only in the first 4 choice tasks? The last 4 choice tasks, they were actually asked to choose between PrEP only versus PrEP plus condoms. So as you can see, we could generate utility scores for different attributes of PrEP, as well as utility scores or preference scores between PrEP only versus condom only, as well as PrEP only versus PrEP plus condoms. What did we find? These are our results. So let me explain to you very quickly. Overall, the utility scores are charted on this forest plot over here. So that line in the middle is 0. Anything to the left of that line means you don't really prefer that. Anything to the right means you actually have preference. We find that overall, participants actually preferred PrEP only versus condoms only because there is a negative preference on condoms only. And overall, participants preferred PrEP with condoms when given that option versus PrEP only. More interestingly, actually, we thought to ourselves, we cannot assume that MSM are homogeneous, in Singapore. And then that's why we did this thing called latent class analysis, which actually helps us to look at different classes of different classes of MSM exist based on the data that we have. What we found was a 3-group or 3-class model that fit best. And we labeled post-hoc or we labeled after the fact as PrEP conservatives, PrEP liberals, and PrEP moderates. PrEP conservatives actually made up most of the sample. The average class probability was 54%. And these MSM are the ones who are a bit more conventional. They will rely on condoms. They prefer condoms only versus PrEP only, and they prefer PrEP with condoms versus PrEP only. That's on the left column. The one in the middle are what we call PrEP liberals. So these are about 15% of the sample. These MSM didn't like condoms and they preferred PrEP only, and they preferred PrEP only when it came to condoms only, and versus PrEP with condoms. More interestingly, actually, we also found that they were most likely to identify as good candidates for PrEP prior to the discrete choice experiment. And lastly, we had the PrEP moderates, which reflected the trends for the overall sample. So they prefer PrEP only versus condoms only, and they prefer PrEP with condoms when given that choice versus PrEP only. One interesting thing at the bottom is that you will see that as the perceived HIV acquisition risk increased and as perceived STI acquisition risk increased, the utility for PrEP actually decreased. So one interesting finding was that for PrEP liberals, thank you. For PrEP liberals, they are less likely or they are less sensitive to increasing risk of HIV acquisition risk as well. So the most sensitive will be the PrEP conservatives because there is actually sort of a wider gap between each data point. So what does this all mean when we are thinking about scaling up of PrEP in Singapore to reach 0 new HIV infections by 2030? What this means is that, okay, let me just go back to this chart over here, that if we look at PrEP liberals, they're the ones who are most likely to exhibit risk compensation related behaviors among MSM, and they will only form maybe about 15% of at-risk MSM. The fact that they are most likely to identify as good candidates for PrEP prior to embarking on the discrete choice experiment shows that these are MSM who already thought of themselves as being at risk, already exhibiting risk behaviors. So actually what we have found aligns with the international literature that risk compensation, yes, might happen as a result of a PrEP, but it might only be limited to MSM who are already at risk of HIV. So how do we ensure scale up of PrEP? This is my last slide. What we could do also right now is that the HIV treatment is on the standard drug list, but not for prevention. So why are we only letting it get subsidized for treatment but not prevention? I think that's one thing that could help with scale up. I'm sure there are a lot more ways that could help with scale up as well, but this is one thing that we can think of right now. Dealing with risk compensation, like I mentioned, 15% are likely to exhibit risk compensation amongst at-risk MSM. What actually is happening is that if we actually scale up PrEP, yes, risk compensation might happen amongst these MSM, but we'll be actually engaging them better in care. It's almost as if we have enhanced surveillance for those who are already at risk of HIV. So this helps us keep tabs on STI, as well as dramatically reduce our yearly incidence of HIV. What we can try to achieve is we can reach from 15% right now up to 50% coverage of PrEP amongst MSM. And this will actually, based on our modeling study, help us achieve zero HIV transmissions among MSM by 2030. So just want to acknowledge the people that have made this happen. We've got Billy, Keisha, Jack from Grindr, Alvin, Nash, Alex, Mark, and Chen Xiong, who were actually the collaborators on this DCE or Discrete Choice Experiment study. Also to everyone else here in the acknowledgement slides. But yeah, I think that's all for my presentation for today. Okay, I need to like have just a slight pause because I'm not thanking myself. So right now, thanks so much for sticking around for that presentation. I will be moving on to the next presentation. So we've got Mr. Kelvin Tan, who's presenting next. So Kelvin is an HIV advocate, and he has been one ever since he was diagnosed with HIV during his late teens. Over the years, he has opened to the public on the discrimination he has faced, both from others and from himself. As a result, he has become a voice for his community, the youth, and the stigmatized. So today, Kelvin will be presenting a little bit about PrEP in the community for us. Over to you, Kelvin.
Okay, thank you so much, Rayner. Hi everyone, my name is Kelvin. I am the current MSM program coordinator for AFA, and I'll be presenting on the PrEP adoption in the MSM community. So within AFA's anonymous testing site, we run the Pink Carpet service. This is a gay and bi man-friendly sexual health service entirely run by dedicated volunteers who identify as MSM and are peer-led for the community by the community. With these shared similar experiences, this encourages the client and the counselor to connect easier in a safe space. So how does the Pink Carpet service work? So first off, the clients will register at our counter, and those who indicate that they are MSM in our client forms are then assigned to a Pink Carpet counselor. They will then proceed on to the pre-test discussion, where the counselor will ask them questions with regards to their sexual history, behaviors, what's their knowledge of HIV. And together they conduct a risk assessment and they find out what's the client's PrEP history. There's also the window period of the HIV test and any further support that the Pink Carpet service can provide for the client after the test. Once that is done, the client will then proceed on for their finger prick rapid test in a separate room. It will take about 15 to 20 minutes for the test results to be released by the same counselor, and then that's where the client will begin the post-test counseling. So this is where the counselor will then release the client's results, and if there are any follow-ups needed, for example, if there's a confirmation test needed, or if there's any clarifications on the test results about sexual health or any referrals to any other community groups, the client can then ask the counselor, and then the counselor can proceed accordingly. Afterwards, there will be everything else that the client wants to know, such as PrEP, relationships, living HIV, STI screening, and many more. In 2019, we tested about 4,000 MSM clients across all ages. Whereas in this year, in 2020, we tested about less than half of that, about 1,800 as of October. There was definitely a drop in clientele due to COVID and eventually the circuit breaker half a year ago, but we are seeing more clients as our ATS opens up more slots. This year, we asked all clients on their history of PrEP use. Based on our ATS report, there were 712 clients who responded to this question. These numbers seem quite familiar from Dr. Yeo's presentation, because this is from our ATS report. So So out of these 712 clients, 16% have been using or previously used PrEP, 28% have heard of PrEP and they are considering PrEP, 35% have heard of PrEP but they are not interested in PrEP, and 21% have never heard of PrEP. One thing to know about this report is that this is asking all clients of all sexualities and genders. The software that we use to collect this data was not able to specifically extract MSM clients' data. Some questions we ask the clients to assess their level of risk is, first, how often do they have unprotected anal sex? How often do they remember if the condom was on before or during sex? How many casual regular partners do they have? How often do they get tested? And do they have a history of substance use? Then based on their risk assessment, we then ask them if they have heard of PrEP. Depending on their answer, if, say for example, if they have never taken PrEP, do they know where to get PrEP? Are they aware of the possible side effects? And are they aware of the cost? Whereas if they have taken PrEP or are taking PrEP, how are they taking their PrEP? Are they taking it correctly? Do they have a valid PrEP prescription? And how often do they go for their PrEP consultation? What we have observed so far can be split into 5 categories. The first category is behavior, where clients avoid heading to clinics such as DSC and NUH, as PrEP consultation is not anonymous. Clients also might avoid PrEP for the fear of potential side effects, and vice versa, where clients actually avoid medical screening entirely and they just take PrEP like that. The second one is accessibility, where there are limited trustworthy online retailers and where clients used to be able to travel overseas to get their PrEP in countries such as Bangkok, but thanks to the travel ban, they are unable to obtain their PrEP. Next, we have affordability, where there are limited financial resources for students and non-working MSM for consultation and medication. The private clinics provide the anonymity that most of our clients wish and desire, but they are expensive. Fourth, we have dosage, where clients take the wrong dosage before and or after sex. So instead of taking instead of taking their on-demand dosage of 211, they might take 212 or 222. And our last category, which is responsibility, some clients actually depend on their partners to take PrEP instead of themselves. Clients also might not check the authenticity of the PrEP that they purchase, and sometimes clients are encouraged to engage in more condomless sex when they're on PrEP. Moving forward, a few plans we have in mind. We are currently running our baseline study and focus group discussions to better understand the concerns of PrEP users. This will help us with the PrEP campaign that we aim to roll out next year, which consists of a PrEP manual for MSM clients, where we'll provide a self-administered risk assessment tool, some more information on PrEP, like how to take PrEP, any side effects, etc., and where can they get a PrEP consultation. We are also exploring having a PrEP consultation with a doctor either on-site or virtually during our pink carpet service. Okay. And that concludes my presentation. Thank you so much.
All right, thank you, Kelvin, for shedding some light on PrEP and its progress in the MSM community here. So now my pleasure to introduce our last panelist for this afternoon's webinar. So we've got Ms. Rayner Tan from Thailand. So Rayner works as a program manager for transgender health at the Institute of HIV Research and Innovation, or IHRI, in Bangkok, Thailand, where she established the Tangerine Community Health Clinic as the first transgender-led health clinic in the region. She manages and provides technical guidance for the development and implementation of HIV and AIDS research and programs for transgender populations, ensuring effective systems and processes are in place to support high quality research and programs to advance the work of IHRI in serving vulnerable populations. So Rayner's previous roles include project management specialist in HIV key population for the United States Agency for International Development, Regional Development Mission for Asia. In addition, Rayner co-founded the Thai Transgender Alliance, the first transgender-owned human rights organization in Thailand. She received a master's degree in international development from the University of Birmingham, United Kingdom. And today she'll be presenting on community participation in the scale-up of PrEP and testing amongst transgender women in Thailand. Rayner, over to you.
Thank you very much, Rayner, for the introduction, and I would like to thank the organizing committee for giving me the opportunity to share my experience on the community participation in scaling up of PrEP and HIV testing among the transgender women in Thailand based at the Tangerine Clinic from the Institute of HIV Research and Innovation, or IHRI. And before I start with other data, I would like to start with this slide. It's sharing you about the size estimation of the transgender populations in Thailand. So it was estimated that there were around 300,000 of transgender women in Thailand. And of those, 62,000 of them, they were sexually active. And of those who were sexually active, around 13,000 of them, they were at high risk of HIV acquisition. And the HIV prevalence among transgender women in 2018 was 17.3%, which is higher than other general populations. And here, this slide shows you about the PrEP uptake in Thailand divided by each service delivery models. On your right-hand side, you can see that the largest proportion highlighted in blue, which is almost 60%, is actually showing the number of the PrEP uptake, which is actually came from the key population-led health services, or we call the Princess PrEP project. So the Princess PrEP project is the key population-led PrEP service provided at the community health centers. So you may be wondering what is the community population, or the key population-led health services is, or KPLHS. So KPLHS actually is a defined set of HIV-related health services, which is focusing on specific key populations. And services are identified by the community themselves and are therefore needs-based, demand-driven, and client-centered. And service provision is actually delivered by trained and qualified key population-led providers who are often coming from the key population members. So, and also how this slide shows you how the KPLHS filling the service gap for key population. So we're actually utilizing the 3 A's and 1 Q approach, which is accessibility, availability, acceptability, and quality. So in terms of accessibility, when you're designing the KP-led health services, your services need to be located in the hotspot, and the service provider need to be flexible at the flexible hours, which is suitable for key population's lifestyle. In terms of availability, not every transgender people, they wanted sexual health services. Your service need to be very comprehensive and responding to their specific health needs. So at the Tangerine Clinic, we also providing gender-affirming hormone treatment as part of the comprehensive health service for transgender populations. And moving to the acceptability, so the staff that train, they always coming from the members of key populations community, because they truly understand the needs of their communities themselves, and the services provided need to be gender sensitive and free from stigma and discrimination. And then here, the Tangerine Clinic is considered as part of the key population-led health services, because the staff, the healthcare team is also identified as transgender people. And we also integrate gender-affirming hormone treatment into the sexual health service package. So it was actually established in 2015, which the leadership from the Professor Prapan Panupak is the former Thai Red Cross AIDS Research Center Director. And here you can see that how the Tangerine provides the comprehensive health service package for transgender women clients at the clinic. You can see that sexual health service is only part of our service package. We also providing hormone-related services on your left-hand side. We use hormone-related services as part of the entry point services and to generate demand among the transgender woman client. Those hormone-related services include hormone prescription, counseling on gender transition, and hormone level monitoring. And you can see that PrEP is only a small part of the health service package among the transgender women at the Tangerine Clinic. Here, this is the performance to date of the Tangerine Clinic as of March this year. You can see that in the past 5 years, the clinic served more than 4,000 of the transgender clients with more than 10,000 visits, clinic visits. And of those, you can see that we had very high HIV testing uptake, which was 95% HIV testing uptake, and 10% they were tested positive. In terms of syphilis, we had around 73% they had syphilis testing, and we found 11% they tested syphilis reactive. However, in terms of PrEP uptake among the trans women at the Tangerine, we had only 13% of the PrEP uptake among these women. So this is something that we need to improve for our program at the clinic. So, and our Tangerine Clinic has been expanded to other provinces in the country. So we act in the past 3 years, we have trained 40 transgender lay providers to become a trained healthcare workers to work at the community-based organization. So far, these 40 transgender lay providers, they can provide more than 12,000 of HIV testing and also almost 700 of transgender PrEP users. And most of the services that they're working on is around hormone services, which is integrated into the sexual health services. And here are the list of the same-day PrEP service flow that we are using at the community-based organization. So our CBO is actually working closely with the public health facility in different provinces. You can see that starting from your left-hand side, the community staff, they evaluate the risk and offer PrEP to eligible clients. And then if the clients agree to get PrEP, they will have blood draw. And then the blood result will be sent through the LINE application, which is the most popular application in Thailand. So the physician will interpret and read the lab result through LINE application, and then they will approve the initiation or continuation of PrEP, and then they can send result through LINE application as well to our community health staff at the community health centers. And the CBO staff will advise on PrEP use to our clients, and then they are able to dispense PrEPs to the client and then make further appointments if needed. So we want to make sure that our client can get PrEP on the same day when they visit the community-based organization. And then during the COVID-19 pandemic, key population-led health services has been adapted themselves. So we provide the support to the CBO staff to rapidly develop the standard operating procedures in order to make sure that we can provide the quality HIV and other health services for key populations. We develop telehealth SOP, express services, as well as we very successful in developing the self-sampling collection for gonorrhea and chlamydia. And it was piloted at the Tangerine Clinic using by the transgender clients. So this slide shows you about the data of the increased number of the transgender clients who conducted self-sampling for gonorrhea and chlamydia. And you can see that the number has been increased. The percentage of the acceptance rate has been increased from May, June, July, respectively. And we still found that those who were collected self-sampling collection for gonorrhea and chlamydia, they still have high HIV, high positive rate for gonorrhea and chlamydia, both for MSM and transgender women. So this slide also shows you that how the KPLHS significantly contributed to the national HIV testing, HIV diagnosis, and PrEP uptake in Thailand. On your right-hand side, you can see that the KPLHS contributed to more than half of the HIV testing uptake among the key populations in Thailand. And also we contributed to almost 40% of the newly diagnosed HIV positive cases among MSM and transgender population nationwide in 2018. So, however, this slide shows you that only key population-led PrEP services, only serving mainly men who have sex with men populations, leaving behind other key populations, including transgender women. And on your right-hand side, you can see that only 7% of the transgender women in the survey, they reported that they were using PrEP, and 60% of them, they did not know about PrEP at all. So we at the Institute of HIV Research and Innovation, or IHRI, with other collaborators and partners, we developed the first transgender-focused PrEP campaign, because most of the campaigns in Thailand was only focusing on MSM populations and leaving behind the transgender populations in the country. So our first transgender-specific PrEP campaign called PrEP in the City. So we are the first PrEP campaign for trans women in the region, which was designed and produced by transgender women. And the campaign actually featured four different characters of transgender women to represent different lifestyle of the PrEP use in their daily life. And we just wanted to highlight again framing messages on this campaign, rather than focusing on risk reduction messages around PrEP use. And the campaign also wanted to increase the visibility of the transgender women in Thai healthcare system. So here are the example of how the PrEP in the City campaign was distributed in the public spaces. This is the picture of the campaign was featured at the BTS Bangkok SkyTrain station. And next slide is also showing the campaign was disseminated at the Asok intersection, which is the one of the BCS junction in the Bangkok metropolitan. And also we are working with the Bangkok metropolitan public transportation to advertise our campaign through the bus wrap, which is running throughout the route or the community where the transgender communities living in order to disseminate our messages around PrEP in the City campaign. And also we are working actively through online channel, including Facebook, Twitter, and YouTube, in order to disseminate our framing messages around PrEP campaign. And here I wanted to show you the preliminary data of the double-sided of HIV cascade among the trans women at the Tangerine Clinic. You can focus on your left-hand side is the HIV negative cascade, showing that 90% of those who were tested HIV negative. You can see that the proportion of those those who were tested negative and agreed to get PrEP is only high. 85% they agreed to get PrEP, and in the last quarter, which is the third quarter in 2020, we found that PrEP uptake was increased by 280% at the Tangerine Clinic. This is actually because of we trained the counselor to change the counseling approach by highlighting on framing messages rather than using the risk reduction screening tool around PrEP use, so that they can feel that they are not judging their sexual behaviors for transgender clients, but rather than using PrEP as another tool or combine HIV prevention to relieve their anxiety when they're having sex. And we also found that by introducing self-sampling collection for gonorrhea and chlamydia among trans women, it also helped raise awareness on HIV acquisition risk among the transgender women as well. We have a very high proportion of those who were tested positive for gonorrhea and chlamydia, and they decided to get PrEP later on. So this is slide show you that lesson learned that how we overcoming PrEP stigma. So as I previously mentioned about the counseling approach and the campaign that we utilizing the framing messages rather than judging their sexual behaviors, and we actually replaced traditional risk assessment with questions that emphasizing client sexual health concern and sexual health goals. So in conclusion, I just want to say that key population-led health service, which is designed and co-delivered by key population, is actually increased HIV service uptake among transgender women and other key populations in the past 5 years in Thailand. And key population-led free same-day PrEP service is the main delivery model to scale up PrEP in Thailand. And framing messages are very crucial in PrEP campaign and entire service delivery processes to overcome PrEP stigma among key populations. And thank you very much. And that's the end of my slide. Thank you.
All right. Thank you, Rayner, for the wonderful presentation. So right now, all presenters panelists have already presented, and we'll go into our panel discussion. So we've got a few questions that have come in through our Q&A, through our chat. Maybe I'll just start off first with one question on the DSC Clinic for Benson. So this question was, how many unique PrEP clients has the DSC seen in 2019 or per year? Because previously you presented on the number of prescriptions. Would you like to maybe just help us with that first?
Yeah, I don't have the figures for which one are unique individuals, but from my just clinical experience, I will estimate about half are new prescriptions and half are for follow-up.
All right, thank you. Okay, so actually there's another question here that sort of is linked to Rayner's presentation as well on basically the issue of maybe anonymity or maybe like sexual orientation being a barrier, something that I see in the Q&A. So maybe the question that I have is directed to Kelvin. Based on your understanding of the MSM community, the issue of cost, the issue of anonymity, the issue of having something that is stigma and discrimination free have all come up throughout all the presentations. Which do you think is the major barrier, the major factor that we need to address to improve PrEP scale up here?
I would say it will be the stigma and discrimination associated with HIV and people who and PrEP users, because with PrEP, PrEP users are seen as more sexually active and more sex deviant. so I feel that is the most prominent thing to consider.
Thank you. Prof. Grulich, so I think one thing that we have the benefit of is learning from Australia's experience as well. Would you have seen any of these issues in Australian MSM, for example, the idea of stigma and discrimination being a barrier or PrEP-related stigma?
Yes, certainly outside the main gay community, Rayner, we are seeing that. We're seeing the highest levels of uptake are in the inner cities. And once we get out to the outer suburbs, where we probably have more anti-gay stigma and anti-gay attitudes, then we are getting lower levels of uptake. And that is our next challenge, is translating the success of the inner cities elsewhere. Another big group we have an issue with are overseas born students who typically come from more socially conservative parts of the world than Australia and can't currently access PrEP cheaply as Australian citizens. It's going to be a key issue and one we see around the world, that we see disparities. We see some populations do well and others don't access. And I'm sure that will be an issue in every population.
Thank you for that. Okay, I'm just looking at the Q&A. We've got one for Rayner. So community volunteers, can they actually give out PrEP or Truvada? Are they allowed to prescribe? Because in Singapore, only doctors can prescribe medication, or maybe nurses or pharmacists can be trained to do so. What has your experience of that been like in Bangkok, and is the legal climate the same?
Yes, so actually before we changed the ministerial regulations, PrEP dispensing by the trained community healthcare worker was conducted under the as part of the implementation science research. But once we proving that the KP-led health services is really contributed to the national HIV response, we working closely with the Ministry of Public Health in order to change the policy. So in 2018, 2 years ago, we successfully in working with the Ministry of Public Health in changing the ministerial regulation in order to allow trained KP-led providers to provide HIV finger prick for blood correction for HIV testing. So they can also provide HIV counseling as well as sampling for specimen sampling collection, and also increasing PrEP dispensing and ARV dispensing as well. So the KPLHS or key population-led health service has actually certified by the Ministry of Public Health by using our data to advocate for policy change. So I think it requires a number of years to change these attitudes, concepts, and policies in Thailand.
All right, thank you for that. Yes.
Can I ask a question of Professor Rulick? In Sydney, particularly Sydney, out of the several thousand individuals who are on PrEP, what is the proportion who get it from the clinics, from the STD clinics, and those getting from GPs, and are there any non-physician prescribers?
Thanks, Roy. So I don't have the exact numbers on that for you, but I'd say probably the majority of prescriptions are now happening through high caseload general practitioners rather than the sexual health clinics. The sexual health clinics were key to the initial rollout, but they probably see, my guess would be about 1/3 there and 2/3 in high caseload general practices. What was your second question, Roy?
No, that was the main question. So the other question is, are nurses allowed, pharmacists allowed?
In the initial phases, before we had approval, a lot of the big sexual health clinics were using nurses a lot to do the prescribing and follow-up. Unfortunately, because of the regulations, now that it's approved and doctors have to prescribe, the role of nurses is less than what it used to be. And that's a real shame, because I do think PrEP really lends itself to a nurse-led approach. Rayner's shown how it could also be peer-led. And I think when we've moved from treatment to prevention, we do have to simplify things. We're dealing with much bigger populations, and I'm a big fan of peer-led services, and I think Thailand's really showing the way there, and we need to learn from Thailand.
All right, thank you, Prof. Grulich. Okay, so I guess one question that I have for Dr. Benson Yeo at this point is that hearing all the presentations right now, and with your understanding of the patients at DSC Clinic, you know, if we were to focus on Singapore, who do you think the DSC Clinic is currently missing out? You know, how does the landscape look like in terms of those prescribing PrEP? And I think Dr. Wong can also jump in at this point. You know, are there differences across different clinics on who you're capturing? You know, maybe even beyond MSM. You know, we talk about those who are at risk of HIV in general.
So at DSC, almost 100%, or I think 100% are men. Majority are MSM, or almost 99 or 100% actually are MSM. So I think what we are lacking, not just at DSC, I think in general, the outreach for PrEP would be to reach the older men who have sex with commercial sex workers. I think outreach and education that PrEP is also safe and suitable for them to use would help in bringing our HIV rates in Singapore down further.
Yeah, so maybe I'm just going to jump in. It's Chen Xiong here. I run the PrEP clinic at the National Center for Infectious Diseases. And in terms of our patient profile, it's probably going to be a little bit different from Benson's at DSC. While it's still majority men who come to us, I do get women patients as well as a few transgender women who seek care and PrEP. Many of the women who are on PrEP do tend to be partners of HIV positive men, and they are, you know, trying to start families and maybe want an additional amount of protection over and above that of having their partners being virally suppressed. I would say of the remaining male clientele, more than half of them would be men who have sex with men. But because we are a specialist HIV center, I do see a slightly higher proportion of people who are here who have transitioned from taking post-exposure prophylaxis and then started taking pre-exposure prophylaxis, or who are partners of or acquaintances or friends of people who are HIV positive and seeking treatment at our clinic, and then know that we have a PrEP service and then come in to see us. Of course, being a restructured hospital and a public hospital, there are some limitations to the amount of publicity and advertising, you know, or raising awareness of the PrEP clinic that we can do over and beyond stating that it is a service provided by the restructured hospital. But that's roughly where we are. Once again, I think I share Benson's concern that we are missing out on a key population, at least in the Singapore context, and that's older heterosexual men who are clients of sex workers, something that we are working on, or trying to work on as well. Thanks for the question.
I agree with you know, the comment regarding we need to demedicalize this thing, PrEP, because, you know, we are talking about much larger numbers of people who really need access, And I've always felt that doctors' times are best looking at other things. Nurses and other healthcare workers can easily be trained to prescribe or to go to counsel about PrEP use and to follow up PrEP patients. High-powered doctors like Chen Xiong and Benson and my colleagues, we shouldn't be the ones dishing out PrEP individually one by one. I really think that we need to utilize primary care, whether it be GPs who are interested in this field, and also try out key population-led clinics. It's something which Thailand has done, and I think, and also pharmacists and nursing staff in other places as well. We really don't have the time amongst the handful of the doctors who are interested in HIV to be looking after patients who want PrEP. And if there's something that needs to be taken away from this session, it is really to see how we can scale up our PrEP usage. There have been comments regarding why our numbers have dropped in the last 2 years. When we don't know, and when we only imagine that the PrEP use is not very much. Okay, I think that as we don't know how many individuals are on PrEP, but certainly there are individuals on PrEP who are getting it overseas and on the grey market and so on, and increasingly in our STD clinics and also in the HIV department. And we, it's very interesting. Really would like to know what's causing the drop. Significant drop which we've noticed in the last 2 years. So I think we really need to expand the pool of people, and not just expand the pool, but also make the economics viable. So looking at laboratory tests and consultation charges, that is going to form a lot of the cost. Because if with generic medications, the cost for generics is actually very affordable. It is doctors' time and labs which are going to be the obstacle in rollout.
Thanks, Prof. Chan. I just want to very quickly address some of the comments at the same time around data, because I think data seems to be a really important part of monitoring and evaluating our progress in terms of PrEP. So I think in terms of how many people actually use so-called unofficial PrEP, we don't have that robust data as of yet. So I think I agree with some of the comments that we need some periodic surveys in the community to show how trends have been changing year on year, as with Thailand and Australia as well in Sydney. I think I'm just going to keep it to like one last question, and it's a very broad question before we move on to the next part of the conference. So the question is for Thailand and Sydney, or Australia rather, Prof. Grulich and Rayner. Hearing the presentations from Singapore today, and based on your experiences in the rollout of PrEP in your respective countries, what kinds of suggestions would you have, for Singapore as we move along the same journey, but perhaps haven't reached that point where you are at right now?
So maybe I'll have, sorry, Rena, after you, Rena. Okay. The one thing I haven't heard, and maybe it's just that I don't know your situation, is about targets, because I think in introducing PrEP, it's great to be introducing it both for the individuals who need it and to end HIV in your community. Both of those things matter. And if you really want to end HIV in your community, then you need high targets, you need ambitious targets. And I did hear you talking about that's what you're aiming for in Singapore in 2030. But to get there, you're going to need targets along the way. So I'd love to see you be able to present data on what proportion of MSM are taking PrEP, what proportion of those at high risk are taking PrEP. But having said that, I was really impressed that you have seen quite a big uptake in recent years, and as we emerge from COVID, it will be very, very important to see that those people who have stopped PrEP because they've stopped having risk get back on PrEP before they start having risk.
Yes, And thank you, Professor Grulich. And I think from my point of view, I think by bringing the HIV or PrEP services to those in need, I think we need to think about how we're going to differentiate the services that we are planning to. So I think we've learned a lot in our region that differentiated PrEP service delivery is very efficient in bringing the PrEP service to those key populations that they are at high risk of HIV acquisition. So I think by having nurse-led key population-led or working closely with the private clinics also, I think it is really contributing to the PrEP target of each country. And I really learned a lot from the Singapore presentation today that we need to expand the private sexual health clinic in Thailand as well. We only have very few private clinics, as we might have very many clients who might not be wanting to go to the public health facility, and they have the ability to pay for the services, which they may want to choose to pay for the services at the private clinic. Sorry, I'm babysitting my nephew. It's the public holiday in Thailand. Sorry, it's noisy.
Thank you. All right. Thank you, everyone, for the discussion. There were a few questions coming in, but unfortunately, we've run out of time for the webinar this afternoon. I just want to extend, our sincerest gratitude and thanks again to all the panelists here who have given up their time, and Rina on a public holiday as well to join us today. I'll pass the time back to Prof. Roy Chan, who will be moving on to the next segment very quickly. Prof. Chan.
Thank you very much. Thank you very much. That was really interesting. I think there were a whole list of other questions which really would have been nice to have been answered verbally, but it just goes to show that there's a lot of interest. We've been talking about PrEP in Singapore for a long time now, for a very long time, and still some ways to go into making it happen so that we can be more confident about ending HIV by 2030 or even before. So it's my pleasure now to go on to the next segment of this afternoon's present program. And this is the segment where we present the Red Ribbon Awards. And these awards are presented to individuals and organizations who have over the years made significant contributions or efforts to prevent the spread of HIV, improve care and support, combat stigma and discrimination, and to advocate for equitable treatment of people living with HIV. This year, we are proud to present the awards to 3 outstanding individuals who have been invaluable allies in our effort to end HIV in Singapore. Next slide, please. The first awardee is Mr. Anwar Hashim, who is Senior Manager of Coordinated Care, Donor and Volunteer Management for Action for AIDS. Anwar's journey of HIV and AIDS, with HIV/AIDS volunteerism started in 2004 when he led a team to Medan, Indonesia for outreach activities which included HIV awareness building. This is under the Singapore International Foundation's Youth Expedition Project. He joined AFA in 2005, first as a counselor at the ATS, or the Anonymous Test Site, and he became clinic manager in 2009 and was responsible for setting up the mobile testing service in 2011. He currently oversees coordinated care, donor, volunteer management. He manages a series of programs, including empowerment workshops for newly diagnosed, as well as peer support groups. He coordinates provision of financial services, financial assistance to needy patients. He coordinates fundraising and collaboration of donors. He started the AFA volunteer journey and centralized training, which eventually work in various services, outreach and education programs. Anwar's experience through the years has made him grounded and taught him patience. Empowering PLHIV both individually and collectively has been Anwar's key motivation from when he started and continues on today. In recognition of his outstanding contribution to care and support of persons with HIV, Anwar Hashim is presented the Red Ribbon Award. Our next recipient is Mr. Terry Lim, who is a Senior Division Manager, HIV Education Programs and Testing of AFA. Terry has had 10 years of experience in outreach work targeting heterosexual men with risk behaviors. He says he's still learning and innovating in this ever-changing environment, especially relevant as we deal now with the new normal of the COVID-19 pandemic. Terry sees himself as a connector and a bridge. He takes the policies, direction, and the big picture, digests them, and then translates them into events and activities on the ground, tailored for the abeng and the uncle audiences. He has succeeded in creating a comprehensive outreach educational program from scratch. It has been key to promoting safer sex behavior change in these groups over many years. Outreach activities that have become the foundation of the heterosexual men's program include safe sex shows in clubs and bars, gatai events, coffee shop and ferry terminal activities. Terry continues to find outreach work challenging and very rewarding, and is glad to be part of a team that fights every day to bring down the rate of infection and to increase AIDS awareness in the community. In recognition of his outstanding contribution to HIV prevention and education, Terry Lim is presented the Red Ribbon Award 2020. Our third recipient is Professor Paul Anand Tambaya. Professor Tambaya is currently Professor of Medicine at NUS and Senior Consultant Infectious Diseases Physician at the National University Health System. He trained at NUS and Infectious Diseases at the University of Wisconsin, and he has been involved in numerous national and international committees. He was a member of the Review Committee for the National HIV Program, Prevention and Control Program in 2012, and has been an active member of the AFA Executive Committee over the last 10 years. He has been involved in the Singapore AIDS Conference since its second edition. He's currently president of the Asia Pacific Society of Clinical Microbiology and Infection, and the president-elect of the International Society of Infectious Diseases. Paul has been a very useful sounding board for new ideas and proposals. I have benefited from his perspectives, his wisdom, and advice on many occasions. In recognition of his generous commitment of time, support, and inspiration, Paul Tambaya is presented the Red Ribbon Award 2020. Thank you all. Thank you, Anwar, Terry, and Professor Tambaya for your dedication to the HIV cause. I believe that's the end of this session. Jing, are you coming on? No. Okay, I think we reconvene at 3 p.m. So you have a few minutes break. Thank you very much. I'll see you all later.
Okay, congratulations again to Mr. Terry Lim, Mr. Anwar, and Professor Paul Tambaya for winning this year's Red Ribbon Award. I would also like to express my appreciation to all the speakers and panelists for sharing your expertise. I certainly have learned a lot about PrEP service in different parts of the world. We will now take a short break. The meeting will resume at 3 p.m. sharp. When we come back, our presenters are ready to update you on the advances made in HIV treatment and access to care. Stay tuned.